In this next section, we'll be looking at the pathophysiology of the large and small bowel. In this section of the GI physiology module, we'll be looking at large bowel physiology, both at fluid and electrolyte balance, as well as GI tract motility. In the GI tract, normally 2 liters of water are ingested per day. About 7 liters of different secretions will enter the GI tract. 8.5 liters are absorbed in the small intestine, with the jejunum being more active than the ileum in absorbing water. 400 ml is absorbed in the colon, and about 100 ml are excreted. As far as absorption of water is concerned, it's principally dependent on sodium and chloride absorption. Absorption is normally isoosmotic, and water will follow solute resorption. The tight junctions that are present in the GI tract are leakiest in the duodenum and the upper jejunum, tighter in the ileum, and tightest in the colon. In the jejunum, sodium is co-transported with protein and carbohydrate breakdown products. This is shown in the bottom left-hand part of the diagram as you look at the screen. Sodium is also absorbed in exchange for hydrogen, as is shown in the top left-hand side. The net effect is absorption of bicarbonate from the GI tract. In the ileum, this is the same as the jejunum, but in addition there is a bicarbonate chloride exchange that's present on the luminal membrane. This is shown on the left-hand side of the screen in the middle. The net effect is an resorption of sodium chloride. Therefore, to contrast, in the jejunum, the net effect is absorption of bicarbonate, whereas in the ileum, the net effect is resorption of sodium chloride. In the colon, there is sodium absorption and potassium secretion. This is potentiated by aldosterone, which increases synthesis of these sodium channels for increased fluid retention and increased potassium excretion. Therefore, patients who are adrenally insufficient and are not capable of producing aldosterone will have hyponatremia and hyperkalemia because they are not able to excrete potassium, as they're not able to upregulate or increase synthesis of these sodium channels in the colonic lumen. In the small bowel, the enterocytes of the villi absorb fluids, but the enterocytes of the crypt secrete fluids and electrolytes. The chloride channels, which normally allow secretion, are usually closed, and sodium and water follow chloride into the lumen. This is mediated by cyclic AMP, and activators of this include VIP, or vasoactive intestinal peptide, acetylcholine, and cholera toxin. Cyclic AMP opens chloride channels, initiating chloride secretion. So in cholera, there is a dysregulation that occurs because these chloride channels, which allow secretion, are usually closed, but the cholera toxin facilitates opening of these chloride channels. Subsequently, sodium and water follow chloride into the lumen. The next diagram that you see is an outline of chloride secretion in the intestine and the manner in which this can be manipulated by the cholera toxin. In step 1, the cholera toxin enters the intestinal crypt cell by crossing the apical cell membrane. In step 2, the cholera toxin, the alpha subunit of the toxin detaches and moves across the cell to the basolateral membrane. There, it catalyzes ADP ribosylation of the alpha S subunit of the GS protein. This is coupled to adenylate cyclase. Because of this, ADP ribosylation of the alpha S subunit inhibits its GTPase activity, and GTP cannot be converted back into GDP. When GTP is permanently bound to the alpha S subunit, adenylate cyclase is permanently activated. Therefore, a vicious cycle is set up with an uncontrolled adenylate cyclase activation. Cyclic AMP levels remain high. As we've already discussed, when cyclic AMP levels remain high, the chloride channels that are normally closed in the apical membrane remain open. When these chloride channels in the apical membrane remain open, sodium and water follows chloride into the lumen. This results in large volumes of fluid being secreted into the intestinal lumen. These large volumes overwhelm the absorptive capabilities of the small intestine and colon, resulting in massive diarrhea. The next slide is an overview in prose form of the schematic that you had on the previous slide. To recap, cholera enters the epithelial cell, the alpha subunit detaches, binds to the alpha S subunit, causes inhibition of GTPase activity so that GTP cannot be converted back to GDP. When GDP production does not occur, then the adenylate cyclase remains permanently activated, resulting in cyclic AMP levels remaining high. The cyclic AMP levels will cause chloride channels to open, resulting in chloride extrusion into the lumen, followed by sodium and water, and the resulting process is massive diarrhea. In the large intestine, segmental contractions of the GI tract occur. These are similar to small bowel segmentations that we discussed in a previous section. However, there are haustra that divide the colon into ovoid segments, and these haustra allow the back and forth mixing of luminal contents. So in the proximal colon, an antipropulsive pattern predominates, and chyme retention facilitates absorption of salt and water. The ileocecal sphincter prevents reflux of large intestinal contents into the small intestine. Mass movements are movements that occur 1 to 3 times a day, and the gastrocolic reflex causes these movements to increase. So essentially this is a push of contents within a significant length of the colon in an orthograde direction. The segmental contraction, which would prevent these mass movements from occurring, sees the haustra disappear from the segment of the bowel involved, and the contents move along in one fell swoop along a narrow tubular length of colon. This means that transport of contents may occur from the transverse colon to the sigmoid colon or rectum in one go. After these movements, the haustra reappear, segmentation rebegins, mixing will restart, and will cease when the next mass movement is due to occur. As I said earlier, they occur 1 to 3 times a day, and the amount of times that they can occur per day may be responsible for mediating how often people open their bowels. So this is a schematic representation where mass movement is being shown to occur in segment C. As you can see in that segment, the haustra have disappeared, the colon looks almost tubular, and a large volume of barium that had been introduced moves from the ascending colon and transverse colon to the splenic flexure and descending colon. After this mass movement has finished, the haustra reappear, mixing will appear again. Subsequently, there will be another mass movement which will carry these contents from the transverse colon and part of the descending colon into the sigmoid colon and rectum. Defecation is triggered by distension and therefore activation of strep receptors in the rectum. This triggers a reflex called the defecation reflex and initiates peristaltic contractions in the colon and rectum. This moves feces down towards the rectum, and there's stimulation of the parasympathetic motor neurons in the sacral spinal cord via the pelvic nerves. Fecal movement into the anal canal stipulates that there's relaxation of the internal anal sphincter. This is under involuntary control. After fecal movement has occurred into the anal canal, after relaxation of the internal anal sphincter, then opening of the external sphincter, which is under voluntary control, results in defecation. In a pressing situation, if expulsion of feces does not take place, the peristaltic contractions will cease. However, additional rectal expansion will need to occur before this reflex is triggered again. If the external pressure gets too high, if the rectal pressures get too high, then this external sphincter will relax. Defecation will subsequently occur. The last mechanism whereby pressures within the rectum are responsible for relaxation of the external sphincter regulate defecation in individuals with spinal cord injuries as well as in infants. In these cases, once there is enough stool there and it creates a certain force or pressure, defecation automatically occurs by relaxation of the external sphincter. One of the most common things that you'll come across in the clinical scenario, both in the pediatric population and the adult population, are diarrheal diseases. We will discuss diarrheal diseases aside from malabsorption, which were discussed in the section on the pancreas. So diarrhea is classified as greater than 250 grams of stool per day. It's acute if it's been present for less than 3 weeks, and chronic if it's been present for more than 4 weeks. There are 3 different types of diarrheal diseases that need to be considered and should be thought of when considering the workup of diarrheal diseases. These are invasive, osmotic, and secretory types of diarrheal diseases. There are important basic screening tests that can be carried out to determine what type of diarrheal disease is present. For example, the presence of fecal leukocytes can be indicative of an invasive diarrhea, such as caused by a bacterium. The second test that's often used is looking at a stool osmotic gap. This is calculated by subtracting stool sodium and potassium multiplied by 2 from a nominative plasma osmolality of 300 milliosms per kilogram. So that's 300 milliosms per kilogram minus 2 times random stool sodium and random stool potassium. A gap of less than 50 milliosms per kilogram from a plasma osmolality indicates a secretory diarrhea. This indicates that the diarrheal fluid is approximately the same as the plasma osmolality. A gap of greater than 100 milliosms per kilogram from plasma osmolality is an osmotic diarrhea, as this indicates that hypertonic stool is present due to the presence of osmotically active substances in the stool. In this table we had outlined the different types of diarrhea and their characteristics. So invasive diarrhea is caused by pathogens invading the enterocytes. There's usually low volume diarrhea, and patients may have diarrhea with blood as well as white blood cells. The most common organisms that are tested for are Shigella, Campylobacter, and Salmonella. Screening tests include fecal smear for leukocytes, and patients will have a stool culture which basically looks at Shigella, Salmonella, Campylobacter, and E. coli, and stool for ova and parasites, such as will be present with Entamoeba histolytica. Secretory diarrhea indicates a loss of isotonic fluid, and the plasma and the stool osmotic gap is less than 50 milliosms per kilogram. This is usually a high volume diarrhea, and mechanisms that precipitate this include laxatives, and enterotoxins that stimulate chloride channels, such as in cholera. There is no inflammation in the bowel mucosa. Serotonin increases bowel motility, and so diarrhea of a secretory nature is often seen in carcinoid syndrome. Fecal leukocytes may not be present in this type of test. There is increased 5-hydroxyindole acetic acid in carcinoid syndrome, and a stool osmotic gap will be less than 50 milliosmoles. In osmotic diarrhea, osmotically active substances are actually actively drawing fluid into the bowel lumen. So hypertonic salt solution will be present. It's a high volume diarrhea, and again, importantly, no inflammation is present in the bowel mucosa. Causes include disaccharide deficiencies and ingestion of poorly absorbable solutes such as magnesium sulfate laxatives. This is why magnesium sulfate laxatives are often used as bowel prep for GI procedures. Fecal leukocytes are not present, and the stool osmotic gap is greater than 100 milliosmoles per kilogram. Next, we're going to talk about diverticulae in the large bowel. Large bowel propulsion diverticulae are found and may be due to a low fiber diet with increased constipation. The sigmoid colon is the most common site of large bowel diverticulae, and they occur in an area of weakness where the vessels penetrate the muscularis mucosa. Importantly, the diverticulum is juxtaposed to a blood vessel and can often bleed. So, for example, in diverticular disease, patients may often present with bright red blood per rectum, and the important thing to remember is that this is an arterial bleed. We just discussed different types of diarrhea. The important thing that was mentioned was that secretory and osmotic diarrheas are not associated with bowel inflammation. Invasive diarrheas caused by pathogens can be found in the presence of colitis or inflammation of the bowel. The other way in which bowel inflammation is found is in the presence of inflammatory bowel disease. Inflammatory bowel disease is classically made up by two different diseases, namely ulcerative colitis and Crohn's. Ulcerative colitis is the most common inflammatory bowel disease, and it's chronic and relapsing. Ulcerations are present in continuity from the rectum to the cecum, and limited to the mucosa and submucosa of the rectum and colon. Ulcerative colitis, perversely, is one of the diseases that may present in patients when they've stopped smoking, and can be improved when smoking is restarted. Crohn's disease is a chronic granulomatous ulceroconstrictive disease, i.e. patients can develop strictures and is associated with transmural inflammation. Because there is transmural inflammation, fistulae can also form, so the patients can present with perianal fistulae. There is discontinuous spread, or so-called skip lesions, throughout the entire gastrointestinal tract, and Crohn's disease is worse in patients with smoking, and they have poorer outcomes with therapy if they smoke as well. Irritable bowel disease is a condition associated with intrinsic colonic motility disorder. It's more predominant in females, and there are two types of irritable bowel disease, IBS-C and IBS-D, i.e. irritable bowel disease with predominant constipation, or irritable bowel syndrome with predominant diarrhea. There are alternating bouts of diarrhea and constipation, and patients will have abdominal pain and bloating, which is relieved by defecation. Importantly, the mucosa in patients with irritable bowel syndrome is normal, unlike in ulcerative colitis and Crohn's disease. Hirschsprung's disease, or congenital megacolon, is caused by the congenital absence of submucosal and myenteric plexuses. In the component on GI motility, we discussed the importance of submucosal and myenteric plexuses in the GI tract for peristalsis to take place. Therefore, peristalsis is absent in this condition or is severely abnormal. Hirschsprung's is usually limited to the colon and is more common in males than female infants. It may often coexist with other congenital abnormalities such as trisomy 21. Hemorrhoids are a bane of lots of people's lives, and there are two different types. There are external hemorrhoids and internal hemorrhoids. External hemorrhoids occur distal to the pectinate line and represent varicosities of venous drainage of the inferior rectal arteries. They're painful, they can be accompanied by irritation, and are prone to thrombosis. Internal hemorrhoids are proximal to the pectinate line and are varicosities of drainage of the superior rectal arteries. So internal hemorrhoids from the superior rectal artery varicosities, external hemorrhoids, inferior rectal artery varicosities. Classically, internal hemorrhoids are not painful as there are no pain receptors present in this area. However, if they prolapse or strangulate for any reason, they then do become painful, and these are complications of these hemorrhoids. In the last section, we discussed the pathophysiology of the small and large bowel. For the purposes of the exam, it's important to understand the physiological underpinnings of water resorption in the small bowel as well as the large bowel. It's also important to know about the underlying principles which result in diarrhea in cholera and know about ulcerative colitis and Crohn's.